prostate. Because the prostate actually is a pretty poorly perfused organ, right? A lot of guys, a lot of men come in, they'll have, in addition to their urinary symptoms of, weak stream, and getting up all night to pee, they'll get recurrent urinary tract infections or prostatitis. Has anybody experienced this or heard of this before?
Because they're not clearing the house.
Yeah, it's not a pleasant experience to have a prostate infection. And once it happens, it tends to happen over and over again. So, and the reason why is because as the prostate ages, the blood flow to it goes down. So that your immune system can't get into the prostate as well as it does to, say, like your lungs, for example. So we utilize that fact when we're doing an MRI of the prostate. When we do the injection of gadolinium, we can measure the speed of diffusion into various parts. And if it has really high diffusion, like for example, if it takes up the blood really quickly, then that's more likely to be a tumor, because tumors are very vascular, more vascular than normal old prostate, put that way.
So is there a branch artery that actually feeds the prostate like an artery feeds the femur head?
No.
Because
it's the opposite. That's a good question. So when you're doing a prostatectomy, when you're taking out a prostate surgically, or I should say when you're taking out, so I took out a kidney and a prostate today, right? So the difference is that when you're cutting the blood supply to the kidney, there's one artery.
Right.
It's as big as my pinky finger going right into the organ. You cut it, it's done, right? Prostate is the exact opposite. You have a network of vessels that enter the prostate from almost all angles. There isn't a one singular artery. So that's part of the reason probably that we have poor perfusion, is because we don't have a dominant blood supply.
Okay, that gives the closer thinking.
Okay. Was there another question over here that I missed?
Before you came, we talked about a couple different scenarios dealing with active surveillance, and they were pretty interesting, and we wanted to kind of throw those out to you to get your comment on. One was Tom's.
Just I'm 3+3 active surveillance, and we're talking about urinary tract infections. I'm still loaded with antibiotics for one of these now, and it was absolute hell. I mean, holding onto a counter like this, peeing blood, almost straight, it was awful. But my PSA has bounced all around the place. It's been, when I first got diagnosed, it was around 10.2 or something like that.
Yeah.
And it stays around there, then it went up to 12, then it went up to 16, and it came back down to 9 something, and now it's slightly back up again.
So not helpful.
No. It's, and what I was saying earlier, I get to see a urologist, 15 minutes every 6 months, so it's hard to jam all the questions.
Is that how much you get now?
What was that?
Is that how much you get now, 15 minutes?
I think it's 20.
Just sit on it.
They tell me I can ask for more.
You can ask for more, but the nurses were telling me today that they expect at least 10 minutes to room the patient. So they tell the doctors you get 15, 20 minutes with the patient, but they want 10 of that to be with the nurse. So I actually get substantially less than 20 minutes.
It's not fun.
Well, I mean, we both are playing the same. You and I are on opposite sides, but we're unfortunately, how do I say this? We're both getting hit by the same machine, basically. But that's off topic. I'm sorry.
Well, the question, how much bouncing around of the PSA should we?
So your experience is another volume in the argument of why PSA is just a bad test. It's just it fails on so many levels. We want it to be, a dial, that tells us that your cancer is getting out of control or it's, going away. And unfortunately, especially in the active surveillance category, right? In other words, a gentleman who has cancer but it has not been treated. So all of that other prostate tissue that's not cancer is still in there, also making it. Your PSA fluctuations are going to be all over the place, just like they are before the biopsy. So, to be honest with you, perfectly honest with you, for the vast majority of men who are doing that, the only reason why we're doing that is because that's all we have. It's certainly not the one, it's not the metric that's making most of the decisions. The metric that makes the most decisions is the biopsy, number one. Okay, so if you look at 10 years, 15 years of follow-up, right? You take 500 guys and you put all 500 on active surveillance and then just follow them for 10 or 15 years, and you ask the question, what data mattered? Like, what ended up changing the course? Now, we all started off doing nothing, and then some number of men fall off and get surgery or get radiation or whatever. What caused that decision to happen? The number one most common thing was your biopsy pathology. So if I walk in the room and I say, hey, Joe, your cancer is 10 times worse than it was 2 years ago based on this biopsy, almost certainly, unless something else is really happening to Joe, he's going to want treatment at that time.
Yeah.
The number two variable that most predicts it is job. Okay? So the PSA is stable, the biopsy is stable, his rectal exam is stable, his symptoms are stable. But this year Joe gets a prostatectomy, and you ask why, and the patient tells you, because I want one. I'm tired of this active surveillance. I'm not comfortable anymore. What seemed like a good idea before, I've changed my mind. I feel like I'm on a I have a bomb in there, and that I've waited too long, and now I just want it taken care of. So in the top 2 things that change and deflect people's decisions, PSA is not even close. I don't even think PSA is like in the top 5 when you look at that analysis. So we do it because we can. We do it because it was how Johns Hopkins University wrote up their original active surveillance protocol. Their original protocol included quarterly PSAs. And as much as we would like to get rid of it, it does actually help a small fraction of men. But the large majority of them have an experience like you, where you have this anxiety about what's going to happen, the number comes, it's higher, you think that the sky's falling, this is bad. We decide to watch it a little bit longer, it comes down. Why did it come down? What did I do to make it come down? I have no idea, right? Or you have a situation like you have personally, which is prostatitis, right? You have an infection, which is known to make the PSA go up. So if and I just said to you that if prostate ever becomes infected once, it's liable to be chronically infected. So as soon as I know I'm dealing with prostatitis in addition to prostate cancer, I might as well just throw the PSA right out the window. It's really almost totally useless at that point when you know that there's a prostatitis in there. It makes the interpretation of PSA impossible, really. So for you and for men who are in that situation, if you maintain the position that if the cancer is getting worse, you want to come off of surveillance, then you don't really have a choice but to do biopsies. Even MRI is not going to help you in that scenario. Because one of the things that is known to make false positives on the MRI is prostatitis. So you can fool a radiologist pretty quickly if you inject bacteria and an infection into the unfortunately. So biopsies will never go away. And for select individuals, they still need to be done fairly regularly because of extenuating circumstances like prostatitis. Yeah, right. Sorry.
Yeah. And this has only been going on for 20 months.
Yeah. Well, with time. So the longer we go without a change in the biopsy strategy, the more likely you're dealing with a truly indolent tumor. If it goes, so if you follow the rules, the guidelines properly, you do a biopsy a year later, maybe you do another biopsy 2 years later, so now the guy's 3 years from diagnosis. if that third biopsy hasn't really changed, the guidelines say up to 5 years is okay. In other words, if we weren't able to detect a change in 3 years, then give this guy a break, right? Because it's not probable that the next 3 years are going to be identical to the last, are going to be different than the first 3 years, basically. Yes, sir.
Does prostate cancer always or mostly grow in little nodules on the prostate?
Most often it grows like mold on cheese.
Like mold on cheese?
Okay. Where you have a dominant spore, and then you have a bunch of little satellite spores.
And that's what you're trying to hit with the biopsy?
You're trying to hit the dominant spore.
The dominant? Okay.
Mothership. We know this because of something called a whole mount sectioning, right? So a couple places like Sloan Kettering, if you get a prostate, if you get your prostate removed at Sloan Kettering, you automatically get your entire prostate literally on the deli slicer in the pathology office. So they're looking at the entire gland.
Okay.
That's not what happens in Tacoma. Okay, so if I take your prostate out, they're going to section it into like 6 pieces and then take little samples from each 6. So that's the standard of care, what I just described. The Sloan Kettering whole mount is a research concept. Because if I chop your prostate up into 6 pieces, I'm going to find the dominant spore. That's going to happen. Right? I'm not going to miss it. But I might miss all of the little baby spores my way, right? And since the dominant spore is the one that tells you the prognosis, we don't care about missing the little ones. But from our colleagues at Sloan Kettering, they're the ones who have shown this to us. So has anybody heard about focal ablation? Like, don't take out the whole prostate, just freeze part of it. The idea here is super popular amongst men, right? So I'm going to kill your prostate cancer, but I'm not going to cause you to be impotent, incontinent. I'm not going to radiate you. I'm just going to go in and laser kill that one spore of prostate cancer. So this is still in 2018. This is a investigational research idea. And the main reason is because we still don't know what those little satellite spores are going to do. Right? I can take out the dominant spore, but if my biopsy missed the little ones, and those turn into a real spore down the road, then I'm not sure that my focal, just killing 1/4 of the prostate is going to help you yet. So I just throw that out there. But that's how it routinely goes.
Do other species have a prostate, the male?
Yes.
Do they have the same prostate cancer problem?
No dog would agree to a PSA test. They are too smart for that.
That's what I agree.
Some dogs make bladder stones for the same reasons that humans make bladder stones. Their prostate gets big and blocks the urine from coming out. Yes, I mean, I'm sure that prostate cancer happens in other species, but we don't, like when an animal develops cancer, they don't always go through the rigorous pathology to figure out even where it came from. If a spot comes in and is coughing up blood and they do an x-ray and they see cancer, usually they just call it and say this dog has cancer, for example. We're not going to go further. So we don't have a lot of good data on prostate cancer in other species. Yes, sir.
I know PSA, as you've been saying, has bad press. What about the PSA test post radical prostatectomy?
Oh, it's a great question. So it's a totally different story, right? So PSA is actually, it was developed as a tumor marker. A tumor marker is, what those words mean is that following a man after he's been treated for prostate cancer. And it is an exquisite tumor marker. Okay, so if you have your prostate removed and you have any PSA in your blood at all, the odds are almost 100% that that's prostate cancer. It's not 100%. There are other ways that can happen. But for the vast, vast majority of patients, if you've had your prostate removed and then you go on to have PSA in your blood, that means cancer is back. And if your PSA is 0, that means cancer is gone. And that is That is an amazing test. Actually, there are very few tumor markers that are better than PSA. So what did they do? They said, well, why not it's such a great tumor marker, let's use it as a screening test. Because it's obviously going to be, it may not be as good of a tumor marker as it is a screening test, but it's such a good tumor marker. Let's just do it on all guys every year and see what happens. Well, that is a great example of, the logic train just went off the tracks. Unfortunately, it is nowhere near as good of a screening tool as it is a tumor marker. So it's a great question. And so we're never going to get rid of PSA. PSA is never going to completely go away because it's going to be the go-to test for anybody who's ever been treated for prostate cancer. But it probably will one day go away as a screening tool because there's just too many ways to fool it before you've had treatment.
What
Yes,
about
sir.
the free PSA versus?
It's the same, right? So free PSA, pro PSA, post PSA, all of these tests are all PSA. It's just how are they existing in the wild, right? So when I draw your PSA and I just send it for a total, if your PSA is floating around free, or it's bound to some albumin, or it's bound to sex hormone globulin, that test picks it all up. The free fraction it just splits out what percentage of that PSA is floating around free, not bound to something else. But if you get a prostatitis, your free PSA, pro PSA, post PSA, PSA total are all just all over the place. But it's still the same protein. And so if you have somebody who is known to have a large prostate, okay, you've been taking care of Bill for a long time, he complains all day about weak stream and getting up all night, and you check his PSA and it's 7, let's just say, and you document that he doesn't have an infection, no prostatitis, he has no sex in the last 2 days, no long bicycle rides, you're confident that this guy's PSA is about as clean as it can be. Doing a free fraction for him is useful because it can help me to decide whether or not his PSA is 7 because he has a big prostate or because he has prostate cancer. But life happens, and that guy did have sex yesterday, or he did go on a 100-mile bike ride 2 weeks ago, or whatever. And so then your free fraction analysis is in the same unfortunate category.
So you started this talking about, what leads you to prescribe treatment. And so you've got an active person, and what it is, I've never gotten a good handle of what that decision is.
Why do active surveillance?
No, when do you say, yeah, let's start doing treatment?
Okay, well, that's a good question, right? So, as I said, the two most common things that change what we do is the biopsy pathology and the patient's personal opinion. He comes in. I didn't say anything.
Right.
He wants it.
So you have no opinion.
Right. So if we're talking about a man who hasn't changed his mind, what will make me change most often is the pathology or MRI findings. Because it's important that we define what is active surveillance and how is that different than watchful waiting. Those are not the same thing. Okay? The difference between them is intent, your intent, what you want. So we have before I put anybody on surveillance, we have a long conversation that basically is, are you ever going to get treatment for your prostate cancer? Is there ever a moment where you care to trade in your quality of life now so that you can live 10 years longer? That is a trade-off that really only you can decide.
There you go.
So, for those of you who have come from my practice, you know my Jimmy Buffett versus Nervous Nelly analogy, right? So if I'm talking to Jimmy Buffett, he literally will never get prostate cancer treatment. Why? Because he's living for the moment, man. He's got Margaritaville tonight, he wants to party tomorrow. If he dies day 3 of prostate cancer, he's totally okay with that, so long as he gets to the party tonight, right? That man should not be put on surveillance. he should be put on watchful waiting.
Right.
Actually, I don't want to see that guy. I'm not going to biopsy that guy. I'm not going to MRI that guy. I'm not going to scare Jimmy with doom and gloom. I'm just going to wait for Jimmy to come back, basically. And if Jimmy lives long enough and he develops metastatic disease, he will come back. Right? He'll come back and he won't be able to pee. He'll lose 20 pounds. He'll have pain in his back, wherever the cancer spreads. The cancer will tell him that it's there. And usually, that person decides treatment at that time. And if we've done it right, that guy comes back happy. Nobody's ever happy that they're dying of prostate cancer. I don't mean that they're fatalistic or something like this. But what I expect Jimmy to say is, well, I just got 8 years of good Margaritaville parrot head living. And yeah, it sucks that I'm dying of prostate cancer now, but I wouldn't have traded in 8 years of sex life and urinary function and such just so I can make it past 78, for example. That is my Jimmy Buffett. And then on the other side of the spectrum is nervous Nelly. I just have to say the words, your PSA is high, and you can just watch his wife and his blood pressure just go astronomical. It doesn't matter that I'm telling them that their cancer is low risk, that there's a super chance that he will never die of prostate cancer, that we can wait and give him 3, 5, 6 more years of good quality of life before we take away his quality of life. I mean, there's a lot of things, there's a lot of reasons to choose active surveillance, but nervous Nelly doesn't hear it. All he hears is cancer. And he knows about his friend Joe, who died of prostate cancer traumatically, or his father, who had prostate cancer at a young age, or something like this. And they almost automatically rush to treatment, or if they do agree to active surveillance, they come back a year later with sweating bullets, and they want to know why his PSA went down half of a point or something like this. And so this person clearly should be on active surveillance, and very often that person will end up getting treatment against my recommendation, which is to watch it. And so these two people don't actually exist. They're fictitious extremes. All of us are somewhere here. But depending on how you claim yourself on that spectrum is going to influence directly how I tell you to act, right? So if you come in, you're not, in my clinic anyways, you're not allowed to have no opinion. Like this is your sex life, your urinary function. I need buy-in from the customer to know how to do this right. Because even if he does have the lethal brand of prostate cancer, it's not going to take him out for a good long time. Like it's not likely that if I found his cancer because PSA went up, that he'll be dead by Christmas. It's more likely 8 years, 12 years from now. So that means that we have a lot of time for you to render your opinion. If we go on to surveillance and we are now just waiting for the data, the objective data to guide us, then it's biopsy, MRI, genetic testing, PSA, in that order, that helps me to tell you when it's time to jump ship and to be treated.
Well, I've been a Jimmy Buffett, but everyone seems to want to pull me the other way.
Yep, that's right. That's right. That's why it's useful to have at least a couple of those visits with the urologist or the radiation oncologist alone, right? Because, I mean, I tell you straight, you get a totally different answer when the man is there by himself versus when his wife is sitting next to him. I mean, it's just a totally different situation altogether. And I've had a number of men sign up for active surveillance, and they come back literally 1 week later, and they're like, I want prostatectomy. Like, wait a minute, we had this thing buttoned up. What are you talking about? Well, I talked about it with my wife. And that's very common. But the cool thing about prostate cancer, if there is one good thing, is that you have time. You have time to have that conversation. If I walk in and I say, you got pancreas cancer, that dude has no time, literally. It's probably too late already. So you don't get a couple months to think about it and research it, and if you wait that long with panc cancer, you're done. With prostate cancer, remember that surveillance means a PSA 6 months from now. Literally, I don't want to see you for 6 months. And I'm not gonna do a biopsy for 9 to 12 months, which means that right off the bat, I'm gonna spot you 12 months before I even care to look to see if it's gotten worse. So when you're in the hot seat, 1 week after the biopsy, you're still peeing blood and you're hurting, and I just said you got cancer, that's a distinctly bad time to be making a decision about what we want to do. It's better to keep coming in and have that conversation and let you go from Jimmy Buffett to Nervous Nelly and back and forth until we all settle down and then come to a good decision. Doug in the back.
I haven't had any symptoms
And you won't.
other than the PSA, and I said, well, what am I looking for?
Don't look. So if you're gonna be on surveillance, go do it.
I've got a sore back.
Right. So it's a great question. Okay, so when we put somebody on surveillance, I mean it. I mean, go away. Go away and do your thing. Go golf, go Hawaii, go garden, whatever it is that is making you happy. Don't be calling me and emailing me, because that's not a quality.
So is that why they were saying don't come to this meeting?
Just stay at home. It's raining. Doug, I think you had a question back there.
I'm relatively new into this thing. I've had the MRI and the results. But when you get the results, what it is that you've got a lesion of such and such a metric size in such and such a metric location, and that's the end of what you get.
Yeah.
So that doesn't mean a damn thing to me. I mean, what does it mean to me?
Well, it does matter.
Well, what is a lesion first? I'd like to
Right.
know.
So-
I think of it as something odd.
I should have brought a picture. When you do an MRI of a prostate, we know what normal should look like. Okay? It kind of looks like an orange within an apple. That's the best way I can describe it to you. Meaning that there is a central zone that is age-related prostate growth that wasn't there when you were born, but it is there now that you're 65. And then on the periphery is a little, like a squished piece of prostate that's been pushed out of the way by the age-related prostate.
The interior.
That's right, the peripheral zone. Okay. And so we have a zillion and two examples of what normal is. So when we say lesion, that means that there is a spot, a dark spot on some images, it's a light spot on other images that doesn't match up with normal. It's there. It's detectable. It can be
It's
seen.
something abnormal,
It's
but
like
not necessarily cancer.
Right, it's like a mammogram. So the best analogy is a mammogram. How many times did your wife get a mammogram?
That helps.
She can't, it was normal, it was normal, it was normal. This year, they found a spot. Well, what is it? Is it breast cancer? Well, I don't know. It's a spot, but it wasn't there before, right? So that's how MRI looks to us, right? I can see it there. Now, they take it a step further and they give it a grade, 1 through 5, right?
Yeah,
So
I've got
the
that.
radiologist doesn't just say there's a bogey at 6 o'clock. Yeah, he says it's PI-RADS 3 or it's PI-RADS 5 or something like this. If you have a PI-RADS 3, what that means is that there's a 50-50 chance, basically. It's equivocal, it's a coin flip as to whether or not that contains, and I quote, clinically significant prostate cancer, end quote. What does that mean? That means Gleason 7 or worse. Distinctly, that does not include the Gleason 6s, the 3+3. And for those of you who don't know, the Gleason 3+3 is the type that's the gray hair disease, right? All of us are going to develop Gleason 6 prostate cancer if we live long enough. And that's not the stuff that kills. It's the Gleason 7 and worse that kills. So the PI-RADS system that you're getting, that score,